From Diamond Pharmacy Services, this is PodcastRx, a monthly show that takes you behind the counter of the nation's largest correctional pharmacy provider. We bring you conversations with pharmacists, nurses, managers, and other Diamond staff about the topics and issues we see in corrections, long-term care, and community health settings. Our chats aren't limited to purely pharmacy topics, and they aren't strictly clinical either. So if you're a healthcare provider or just enjoy healthcare podcasts, we think you'll enjoy this show. On this episode, Chris Bender of the Optics Clinical Pharmacy team breaks down recent developments surrounding the pneumococcal, hepatitis B, and shingles vaccines. We discuss the impact of new vaccines on the market for pneumococcal and hepatitis B, and how they compare with what's already available. And we also talk about the updated CDC recommendations for all three vaccines. I'm Adam Campbell. Welcome to PodcastRx. I'd like to welcome back Chris Bender from the Optics Clinical Pharmacy team to another edition of PodcastRx. Chris, we're always really appreciative of your time and expertise, and really you could say you're pretty much like a permanent guest host now.
Well, it's definitely a good feeling, and I want to say thanks for always having me on the pod, Adam. I always love being here, and I always look forward to our discussions, particularly this one today. Yeah, absolutely. Can't wait to get into it here. So, Chris, you and your optics colleagues, you're always keeping a close eye on changes in medicine. That's, of course, your job. And there's been some notable changes over the past few months regarding vaccines, specifically the pneumococcal, hepatitis B, and shingles vaccines. Now, these aren't just diseases that are prevalent in the community at large. They're also prominent in the corrections and long-term care populations that you work with every day. That said, I wanted to talk with you today about these vaccine changes and what providers should know if they aren't already familiar. Yeah, I think that's a really great idea. And I was really glad when you invited me to discuss this topic, because you and I both know, just as all of our listeners know, that over the past 2 years, we've really spoken at length regarding COVID-19 vaccination. But it's also important to remember that while COVID-19 was happening, there was also a lot happening in the overall vaccination landscape. So I think it's kind of time for us to take a step back and to refresh when it comes to some of the non-COVID-19 vaccinations.
I couldn't agree more, Chris. And to get started with this vaccine roundup, if you will, let's start with the pneumococcal disease. So the pneumococcal vaccines, the big development here is that we've seen 2 new FDA-approved vaccines in the past year, Prevnar 20 and Vaxneuvance. And these new vaccines join Prevnar 13 and Pneumovax 23, both of which have been around for quite some time. So to start, how do these new vaccines compare to what's already available? What do they do differently? And how do they improve coverage against pneumococcal disease?
Yeah, so as you mentioned, there are now 4 pneumococcal vaccines currently on the market for adults. So just to reiterate, we have Prevnar 13, Vaxneuvance, Prevnar 20, and Pneumovax 23. We can really compare and contrast these vaccines in 2 different ways. So first is based on vaccine type. Now, if you'll recall our vaccine overview episode from last year, you'll remember that there are many different vaccine types. So for example, we have live vaccines, inactivated vaccines, mRNA vaccines, etc. Well, Prevnar 13, Vaxneuvance, and Prevnar 20 are all considered conjugate vaccines. And essentially, conjugate vaccines combine a weak antigen with a strong antigen so that the immune system basically has a stronger response to the weak antigen, kind of like a buddy system. So in this case, Prevnar 13, Vaxneuvance, and Prevnar 20 all just use a fragment of the pneumococcal bacterium, which is the weak antigen. And they do this in this way because they don't want the vaccine to cause pneumococcal disease. But in order to amplify that immune response, they also need to include a protein from another pathogen, which in this case comes from diphtheria, as the strong antigen. So it's important to highlight here that this diphtheria protein also cannot cause the disease, but really it only serves to amplify the immune response to the important part, to the pneumococcal component. So all of this is a really long-winded way of saying Prevnar 13, Vaxneuvance, and Prevnar 20 are all conjugate vaccines, and they provide a very robust immune response. Now, Pneumovax 23, on the other hand, is a polysaccharide vaccine. So it does the same thing. It also uses a fragment of the pneumococcal bacterium, but it's different because it doesn't include any conjugate component. So for this reason, we tend to think that Pneumovax 23 produces a somewhat less robust immune response. And that'll be important when we consider the general vaccination recommendations.
Now, Chris, I'm sorry, Chris. I just wanted to clarify one thing. When you started, you mentioned that these are 4 vaccines on the market for adults. And I just wanted to clarify that's what we're talking about today, these vaccine changes as they relate to adults primarily. Pneumococcal and hepatitis B vaccines, those are routine infant vaccinations. And what we're covering today does not necessarily pertain to that.
Yes.
Just wanted to clarify for the listeners.
Yep.
Okay.
Yeah,
okay.
Absolutely. So we'll be just discussing in the realm of adult vaccination for today. So
okay.
That was one distinction. But the second point of comparison, and this is an important one, is their coverage. So just for reference, there are 93 different versions, or what we call serotypes, of the pneumococcal bacterium. And they all really differ with regard to their ability to cause disease, their ability to cause different severity of disease, and their invasiveness, meaning like some strains go into, are more invasive into different parts of the body. Unfortunately, as you could probably imagine, it's quite difficult to get 93 different antigens in a single vaccine. That would be fantastic, but it's just not possible. So manufacturers have had to pick and choose which ones of these to include in their vaccines. Now, it might be a little intuitive, but just to review, Prevnar 13 contains 13 different serotypes. Vaxneuvance contains 15. Prevnar 20 contains 20, and Pneumovax 23 contains 23. Now, there is a lot of overlap with regard to the serotypes that each product contains, but I just want to mention that the most notable improvement with these 2 new vaccines, those being Vaxneuvance and Prevnar 20, is that they both include 2 serotypes. The names of them are 22F and 33F for those interested, that were not included in the Prevnar 13 vaccine. What's important about these is that these serotypes are known to cause more invasive disease. A good example of this would be meningitis. They also tend to be resistant to antibiotics, tend to have higher rates in mortality. I should note also that Pneumovax 23 also includes these more invasive serotypes, but because, as we mentioned briefly, as I mentioned just before, because of its less robust immune response, there was always this need. There was always this outlying need for conjugate vaccines with broader coverage because they produce a more robust immune response. So essentially, Vaxneuvance and Prevnar 20 are improvements on the existing Prevnar 13 vaccine.
Now, Chris, this is very much a layperson question, but are there any additional considerations to make when you're choosing between Vaxneuvance and Prevnar 20, just given that there's a difference of 5 serotypes? My first thought is, well, if I was asking for the vaccine or recommending it, well, Prevnar 20 has 20, and that's 5 more than Vaxneuvance. Well, wouldn't I just use the 20 and be done there? What do you have to consider when you're recommending these or learning about them with the difference to serotypes?
Well, it would be kind of intuitive to say that Prevnar 20 is just better from a broader coverage perspective than Vaxneuvance. Obviously, Vaxneuvance contains 15. Prevnar 20 contains 20. But really what it comes down to, and I think we're going to be discussing this here in a moment, is basically there is a difference in the recommendations in the use of these 2 medications. And that's how I kind of stratify it. Because, not to get ahead of myself, but with regard to the treatment, the vaccination recommendations, it's simpler to use Prevnar 20, whereas it might be a little bit more complicated to use the Vaxneuvance because you're losing some of your coverage. So that's what I consider, and that's why I don't have any vested interest in either of these products. But to me personally, I would prefer Prevnar 20 simply because it's more inclusive. And they are also both the same vaccine technology. So there is no clinical differences in terms of how well they work. So you're almost getting more bang for your buck with the 20 as opposed to the 15. But I should note that typically there is a slight cost, that goes with it. The 20 is a little bit more expensive than the 15.
Well, let's move on to the actual recommendations themselves. Of course, in the wake of these new vaccines, the CDC and its Advisory Committee on Immunization Practices, they've updated the overall recommendations for them. So, what exactly are these revised recommendations, and how did they come about, aside from the introduction of the new vaccines?
Sure. So I do want to start off by saying that the indications for pneumococcal vaccination have not changed. So the people who would qualify for vaccination, they're still the same as who would have qualified last year. So this includes two groups of people. The first being people 65 years of age and older, and the second group being people 19 to 64 with certain underlying medical conditions. Now, I will say that this list of conditions is fairly extensive, so I would simply advise our listeners to review the recommended adult immunization schedule, which of course we'll provide a link in the show notes. But to sort of summarize, these are patients who are smokers or alcoholics, have chronic heart, lung, liver, kidney diseases, have diabetes, have cancer, have asplenia, meaning they don't have a spleen, or functionally they don't have a spleen, or they may be taking immunosuppressing medications. So again, very extensive list, but it's the same as what it was. Now, with regard to the actual vaccination recommendations, they've actually made things a lot simpler for vaccine naive individuals, meaning those people who have not yet gotten any pneumococcal vaccines. So in the past, it was very convoluted. We were often thinking about when to give their next dose of Pneumorecs 23 and whether or not they got it before or after the age of 65. And it got very confusing depending on the clinical scenario. Well, now it's a lot simpler. If a patient qualifies for vaccination, there are two options. And this kind of calls back to where and how I make my selection between Vaxneuvance and Prevnar 20. So the first option is a single dose of Prevnar 20 and done. The second option is a single dose of Vaxneuvance followed by a single dose of Pneumovax 23. And the reasoning behind this is because you have to kind of compensate for the lack of coverage, of the lack of Vaxneuvance's coverage. So they kind of top it off, so to speak, with a Pneumovax 23. Now, the timing between those two vaccines is also important to consider because it should be at least a year apart, unless the patient is immunocompromised, in which case they get it a little bit sooner, as soon as 8 weeks after one another. But regardless of the option chosen, the patient is then considered to be fully vaccinated for life. And just kind of calling back to the last question, that's why I kind of prefer Prevnar 20, and not to get into too much of the nuts and bolts of it, but I said, there is a bit more of a cost associated. It's a little bit more expensive than Vaxneuvance. But if you think about it from a cost and a time standpoint, you only have one injection with Prevnar 20. Yes, it is a little bit more expensive up front, but you have to factor the cost of two vaccines if you were to get Vaxneuvance followed by Pneumovax 23. And you also have to think about having the patient come back to the clinic, have to think about the patient, their time having to go back to the clinic. So again, I don't have a stake in either one of these, but I tend to be a simpler guy, and I tend to prefer one and done as opposed to a two vaccine technique.
You brought up that the timing between Vaxneuvance and Pneumovax 23 should be at least a year, unless, of course, the patient is immunocompromised, and then it could be as soon as 8 weeks. Why a year in between those two shots?
It basically just gives the body enough time to develop immunity. It almost serves as a booster in that case. So if you think about it in the context of Hep B vaccination, for example, we don't give you our traditional Hep B vaccine schedule has always been 0, 1, and 6 months. You don't just jam them all together at 0, 1, and 2 months. You need to give the body time to develop immunity, and then you kind of give an extra booster, and it allows your body's immunity to kind of ramp up higher. And then by waiting another extended period of time, giving that third dose, it allows your body to ramp up even higher. So this way, waiting a year between doses, it kind of gives your body a year to ramp up the immune response, and then it gives you an extra boost, so to speak, at the 1 year time, at the 1 year time frame.
With these new recommendations, the new vaccines, what do these changes in the pneumococcal vaccine landscape mean for what's already here? Do these new vaccines render the old ones obsolete, essentially? And what about the patients who've already been vaccinated with these older vaccines?
Yeah, I mean, well, for one, Prevnar 13 is no longer even mentioned in the recommendations, so its use is basically eliminated. We may also see a slight reduction in the use of Pneumovax 23 over time, of course, and this is just my own thoughts. And this is because in the past, there were some cases in which patients could receive up to 3 doses of Pneumovax 23 over their entire lifetime. And I'm thinking mostly of the case of like immunocompromised patients. But now, vaccine naive patients, so moving forward, patients would only receive at most a one-time dose of Pneumovax 23 in their lifetime. So you're going to see a hit to the utilization of both of the existing products. The biggest potential source of confusion is going to be in those patients who've already been vaccinated with either Prevnar 13 or Pneumovax 23. And this is where I want to make a huge plug for the CDC's app called PneumoRecs, PneumoRecs. And of course, we'll include a link to this in the show notes. This app is honestly fantastic. And I know because I've already used it many times. All you need to do is you need to enter the patient's age, any special underlying medical conditions, and any of the vaccines that they may have already received in the past, any of the pneumococcal vaccines that they may have received in the past. And basically, it's just going to tell you which, if any, of the pneumococcal vaccines that they should receive. So it just kind of like spits it right out for you. It's a very convenient tool for a busy clinician to use, or even for a patient to use themselves, to inform themselves, before going into a visit with their provider. So I think it's a fantastic tool. And I recommend that because there's going to be many different possible scenarios based on a patient's various underlying conditions, their age, and whether or not they received one or both of those vaccines. It makes it very, very nuancey and very confusing. So I would just kind of like I would just highly recommend using that. With that said, there are some general principles that we consider. So for patients who have received a Prevnar 13 in the past, remember Prevnar 13 and these new products are all conjugate vaccines. For patients who have received a Prevnar 13 in the past, these new vaccines are not recommended in this patient population, even though, to me, personally speaking, it would seem that you would want the benefit of the broadened coverage. As of right now, CDC, ACIP, they've made the recommendation that if you had a Prevnar 13 in the past, you don't need another conjugate vaccine now at this point. That may change, but for right now, we don't have anything to go off of to suggest that you need that. So these patients would continue to basically follow the old recommendations. So to conceptualize this, I like to think, a typical patient who would have received Prevnar 13 in the past would probably likely be a patient with, say, an immunocompromising condition. So according to the old recommendations, these patients should receive Prevnar 13 followed by Pneumovax 23. And without, confusing everyone, these patients could receive up to 3 doses of Pneumovax 23 depending on their age when they started vaccination. So for the patients who have already received Prevnar 13 in the past, it's basically recommended to just give them their next Pneumovax 23 dose whenever that would be appropriate for that patient. On the other hand, there are going to be individuals who may have only received Pneumovax 23 in the past. And a good example of these would be patients who were smokers, asthmatics, or even, we all know, someone who may have gone out and gotten Pneumovax 23 on their 65th birthday because they saw, to do that on a commercial. For these patients who have only received Pneumovax 23 in the past, they may receive a single dose of either Prevnar 20 or Vaxneuvance. So they may receive a single dose of either of these new, quote unquote, better products. And essentially the thinking is we want to get every individual vaccinated with a conjugate vaccine, because now you think about it, all newly vaccinated individuals are going to be receiving conjugate vaccines moving forward. So in a way, they don't want to leave those people behind who have only received Pneumovax 23. They kind of want to, for lack of a better term, give them a booster with this better type of vaccine technology, with a conjugate vaccine. So I know that's a lot, and I apologize, but because these special scenarios are very confusing, I number one would recommend the PneumoRecs app, but I would also recommend checking out the CDC's pneumococcal vaccine timing in adults, or pneumococcal vaccine timing for adults document. And we'll include a link to this as well in the show notes.
Yeah, absolutely. Well, the PneumoRecs app, the pneumococcal vaccine timing for adults, and also the adult immunization schedule that you referenced at the top of the discussion. We'll have all those in the show notes. Before we move on to the hepatitis B vaccines, let's take a quick break.
Remember the Diamond Drug Information Center? That group of expert pharmacists who help Diamond customers with their medication questions? Well, I'm here to tell you that they're a thing of the past, but not in a bad way. No. The Drug Info Center has a new name and a new mission. We're proud to introduce the Office of Pharmacy Therapeutics and Integrated Clinical Services, or OPTICS. Instead of offering just drug information, the pharmacists of OPTICS are moving their services closer to direct patient care. Whether it's through collaborative formulary management, medication therapy management, or individual patient care plans, the OPTICS team is ready to integrate their clinical pharmacy expertise into the day-to-day operations of medical teams in corrections and long-term care, and they'll continue to offer the same drug information resources they've provided in the past. To get a clearer view of OPTICS and its mission, go to diamondpharmacy.com/OPTICS team to learn more. Now back to PodcastRx.
As with pneumococcal vaccines, there's also a new vaccine product on the market for hepatitis B, PreHevbrio. It joins Engerix B, Recombavax HB, and Heplisav B. Chris, I pretty much have to ask you the same questions with the pneumococcal vaccines. How does PreHevbrio improve upon what's already available? And how does it work in relation to the existing vaccines? And lastly, how does it ultimately improve protection against hepatitis B?
Sure. So the main difference of PreHevbrio compared to the other three existing products is that PreHevbrio contains 3 hepatitis B surface antigens. Compare that to the others that only contain 1 hepatitis B surface antigen. So on a theoretical level, by containing more surface antigens, this should result in a more robust immune response, as well as broaden the coverage against the hepatitis B virus in the future event of any sort of viral mutation, which has to this point been a fairly low risk, but nonetheless, it's a nice technology to have moving forward. Now,
yeah, and I'm sorry, Chris. I just wanted to jump in real quick. If anyone is confused by what antigens are, what that all means, I would suggest going back in our episodes of PodcastRx to another episode we did with Chris called "Vaccinate This," I believe. That was the title of it. Yes, that's just a general explanation of vaccines, and it's really just a great primer for anyone who doesn't quite understand how vaccines work. Chris really gets into the weeds on it. It's a great episode, so do go back and listen to that. Continue, sir.
Listen, I'm always willing to pause for a nice callback. So, but just as a refresher, a quick refresher, antigen, for lack of a better word, is just the thing on the bacteria, the virus that causes or induces the immune response. What's the first to everyone's mind these days? The spike protein on SARS-CoV-2. The spike protein is the antigen. So just like the coronavirus particle, the hepatitis B particle is covered in these little spikes and things like that. And there are actually 3 surface antigens on there. So that's why historically they've only used 1 of them, but this new product, PreHevbrio, contains all 3 of them. PreHevbrio.
Oh, I'm sorry. I will let you get into PreHevbrio. I just wanted to clarify that episode was called Immunize This, not Vaccinate This. So if you want to look back through the episodes of PodcastRx, yes, Immunize This with Chris Bender, and he'll give a more detailed explanation of what he just touched on. The floor is yours.
It's important
Yeah.
that we do that we name them properly whenever we're doing the compound. So that's good.
Right.
So yeah,
The floor is
PreHevbrio
yours,
has
sir.
good theoretical. Thank you. So PreHevbrio has good theoretical data, but it also has good clinical data too. So PreHevbrio has only been studied at this point against only one of the existing vaccines, and that's Engerix B. In those clinical trials, PreHevbrio performed just as well as Engerix B in the general adult population. This included younger patients down to 18, and that should be expected because all vaccines typically do well in the younger population. But it actually performed better than Engerix B in a slightly older patient population, those individuals 45 years of age and older. In addition to this, it also appears to work faster. It starts to work really well after only 2 doses, as opposed to you still need 3 doses, but it starts to work after 2 doses, whereas you don't tend to see a great response after only 2 doses with like Engerix B or Recombavax. And also, too, it's even demonstrated good results in patient populations which historically have been difficult to induce immunity in. And good examples of this would be patients with HIV, patients with end-stage renal disease, and even in patients who did not respond to a previous series of hepatitis B vaccine. And that's a really important patient population that we're trying to get better vaccines for. What do you do with those patients who simply did not mount an immune response to a full series of Engerix B? So this, as well as Hepatitis B, could be good options in that patient population. Now, the only concern that I have with this comparison to Engerix B is that at least historically, Engerix B has not been the most effective option, at least not in like older patient population, diabetic patient population, the more like complicated, patient populations in clinical trials. So that could have made it easier to show a large benefit. Obviously, it would be nice to be able to compare PreHevbrio to the other 2, those being Hepatitis B and Recombavax HB, just to get an overall clearer picture on its general effectiveness compared to the group as a whole. For now, all I can really say is that based on my own indirect comparison and my own reading of the clinical trials, PreHevbrio appears to be comparable to Recombavax HB and Hepatitis B. And this has kind of been echoed by the ACIP. They've just voted to recommend PreHevbrio equally with all other options, meaning they don't have a preference for one vaccine over another. And they said that all 4 will be listed in next year's adult vaccine schedule. I do want to note here that the main clinical trials did not include persons on dialysis, persons who are pregnant, or persons who are breastfeeding. So we may have a little bit of some limitations with regard to who can receive this vaccine ultimately, but that data is always later to come, as we saw with COVID vaccines. So this ultimately may be a moot point moving forward, but for now, this is something to consider. PreHevbrio is given as a 3-dose series over 6 months, just like Engerix B and Recombavax HB, which we kind of already mentioned before. The only outlier in this group of vaccines is Hepatitis B, which is only given as a 2-dose series over 1 month, which is, in my opinion, a fairly significant benefit of Hepatitis B over the others.
And with like the pneumococcal vaccines, is there a difference in price with that 2-dose series over a month versus the others?
Yeah, so typically the Hepatitis B, because it is a slightly different vaccine type, it works a little bit more robustly and it is done in a quicker time period. Naturally, it's a little bit more expensive. So what I consider is it's the price of convenience. So that's something to consider among these vaccines. PreHevbrio is newer. We don't have a lot of pricing information about it right now, but if I had to guess, it's going to fall. If you have Engerix and Recombavax, Engerix B and Recombavax HB sort of on level pegging down at the bottom, the cheapest, and Heplisav B as the most expensive. PreHevbrio is likely to fall somewhere in the middle.
So as with the pneumococcal vaccines, you also have new CDC recommendations for hepatitis B lately. And these are recommendations that are going to make more of the population eligible for the vaccine. So how does the broader recommendation compare to the previous guidelines? What happened to inspire these recommendations? And how does the latest vaccine fit into all this?
Yeah, so historically speaking, the recommendation was to vaccinate unvaccinated individuals who were considered to be at risk. Now, examples of risk factors would be chronic liver disease, diabetes, HIV infection, engaging in risky sexual exposure, drug use, dialysis, or even incarceration. Now, this is a decently extensive list, but by no means is it inclusive of the entire population. And the CDC realized this. They realized that the U.S. was actually not on track to reach the World Health Organization's goal of hepatitis B elimination by the year 2030. So in order to combat this and to kind of ratchet down, the recommendations are now broader. So all unvaccinated persons ages 19 to 59 should be vaccinated against hepatitis B, regardless of whether or not they have any of those risk factors. They also say that individuals 60 and older with risk factors should be vaccinated as well. And then they go on to say, well, even if they're 60 and older and don't have risk factors, they could still be considered for vaccination. So essentially, my reading of this is that all unvaccinated adults are likely candidates for hepatitis B vaccination. So with regard to PreHevbrio, like how does the new vaccine play into this? At this time, it simply provides another tool in our vaccine armamentarium. Like I said before, the ACIP doesn't prefer any particular hepatitis B vaccine over another, but in my opinion, it's just always good to have more options.
Yeah, for sure. And I love that you brought back armamentarium for a second straight episode. I think if you ever have your own podcast, you have a title for a show right there. Just saying.
Listen, we're all about the callbacks here.
That's right. So what implications, Chris, do you think the new recommendations and the new vaccine will have on the population at large, which you touched on a little bit, but what about the nursing home and correctional populations that you're seeing every day as part of optics?
Sure. And I mean, obviously, I do believe there's going to be a large opportunity to increase our hepatitis B vaccination rates among the general and the nursing home population. I mean, sure, in the past, there were people who qualified previously. First that come to mind would be like patients on dialysis or patients with diabetes, but that wasn't inclusive of those entire populations. So there's still going to be large segments of the population who remain unvaccinated and who would qualify now. The correctional population, on the other hand, it's going to be interesting because if you'll recall, this was already a population that qualified for hepatitis B vaccination. So I'd like to think that this expanded recommendation isn't going to move the needle much for correctional population because they should have already been vaccinated when they're in the facilities already. However, if there were any remaining holdouts among correctional facilities or correctional providers, hopefully these expanded recommendations will help to provide, further justification for the necessity of vaccination during incarceration.
Thanks for listening to PodcastRx from Diamond Pharmacy Services. If you're a fan of the show and have any topics you'd like to hear us discuss, or if you have any thoughts on a particular episode you'd like to share, please email us at podcastrx@diamondpharmacy.com. And while you're at it, please rate and review our show wherever you get your podcasts. Your feedback helps us make the best show possible for you. And as always, we appreciate your feedback and support. Now back to the show.
We're back on PodcastRx talking with Chris Bender about vaccines, new recommendations, new vaccines, and the last disease state that we wanted to cover today, the final vaccine that we wanted to cover today is shingles. Unlike the other two disease states, there's no new vaccine to report here, but the CDC and the ACIP did make a new recommendation for who should receive Shingrix or recombinant zoster vaccine. So what is this new recommendation and why was it made?
Sure. Well, first, just as a refresher, shingles vaccination was and still is recommended for all adults 50 years of age and older. But now there's an additional patient population who qualifies. These are patients 19 years of age who are immunocompromised. Now, this includes many different individuals. These can range from cancer patients, stem cell transplant patients, HIV patients, or even those just simply receiving immunosuppressing medications. There's also been a change to the recommended dosing schedule for Shingrix based on the individual's immune status. So for immunocompetent, meaning these are patients without immunocompromising conditions, typical patients should receive 2 doses separated by 2 to 6 months. Immunocompromised patients, simply by nature of their underlying diseases, they should receive their doses a little closer together to kind of bump up that immunity a little bit quicker, with 2 doses separated by only 1 to 2 months. But like I said before, I tend to be a little bit of a simpler guy. I like to have simple explanations and simple things to remember. So if you just remember 2 doses separated by 2 months, you'll technically be correct regardless of the patient population.
Now, Chris, just to clarify why that recommendation was made, that's because shingles can lead to more severe disease and even death among that immunocompromised population. Is that correct?
Yes, that's very important to highlight. They noticed higher rates of shingles incidence in those patient population and higher severity rates when it does occur. Yeah.
So, and to ask this again, as with the hepatitis B portion, what implications do these new recommendations, what do they have on the population at large and again, the nursing home and correctional populations that you work with directly?
So generally speaking, we may see increases in shingles vaccination pretty much regardless of setting. And that's because immunocompromised patients exist in all 3 areas of focus, general, long-term care, nursing home, and then correctional. However, I do think this recommendation has the potential to impact the correctional setting the most. And this is because, the correctional setting tends to have a disproportionately larger HIV population than your general or nursing home settings. So by nature of having HIV, more patients in the correctional setting will now qualify for shingles vaccine. So I think this will have the potential to impact existing correctional institutional protocols.
Now, before we wrap this discussion on vaccines, I wanted to revisit something that you referenced at the top of the show, which was that extensive discussion of COVID-19 vaccination may have overshadowed the developments that we talked about today. And as you remember, and is still going on, a big part of the dialogue surrounding the COVID vaccinations was vaccine hesitancy. Now, of course, COVID vaccines have an entire cultural, political elements that the 3 vaccines today really do not. But because we talked about new vaccines and expanded recommendations, Chris, do you think broader vaccine hesitancy that we're seeing in the COVID-19 area, do you think that might have any effect on how these new vaccines and recommendations that we talked about today are received?
Well, I think that's a really good question, and unfortunately, I don't think anyone has the right answer here. But I do think that with regard to vaccine hesitancy, I do believe that the people who were hesitant to the COVID vaccine were probably, there's a large degree of overlap in that Venn diagram of people who would have been hesitant to the COVID vaccine, as well as being hesitant to your more traditional vaccines like we're discussing today. But, and this is the eternal optimist in me, I do think that moving forward, the COVID-19 pandemic may have a positive impact on vaccine uptake in the general population, because now, infection and disease control is so much more salient in the public zeitgeist now, to where I do think that people are going to be more prone to getting vaccines for more routine vaccinations, because a lot of these vaccines are relying on more traditional vaccine technology. I mean, at this point, mRNA COVID vaccines are fairly commonplace, but at the time when they first came out, that was novel technology. What we're discussing today is very commonplace, technology that's been around for decades in some cases. So I do think that the idea of getting vaccinated with these products is not as scary because they've been around for a while. And another thing too is we're always used to throwing around the idea of, hey, this is a Hep B vaccine. It's very common. So I do think that in general, this will help to increase the uptake in vaccines. And I know that this is adult population, but I do think it's also going to have an impact on the child or adolescent population as well, because we've seen the excitement of COVID-19 vaccines as they become available for the pediatric population. I think it's going to draw attention and remind everyone that, hey, there are a plethora of vaccines, scheduled recommended childhood vaccines that people should and do get. But I think it's also going to have a positive impact on the younger population as well.
Yeah, let's hope it has a positive impact on all populations, of course. Chris Bender, thank you so much for joining us once again on PodcastRx. I know we'll be talking to you again very shortly about another exciting topic and topics. So again, thank you so much for sharing your time and your expertise, and we'll see you again very shortly, I'm sure.
Absolutely. As always, Adam, pleasure to be here, pleasure to speak with you, and I look forward to our next time.
All right. Take care, Chris.
Take care.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.